I am going to speak about dental caries today. There is no person in this universe who has not experienced dental caries. It's the most common infectious disease of the oral cavity. Now let us see what is dental caries, the definition of dental caries. Dental caries is an infectious, irreversible microbial disease of the calcified tissues of the teeth characterized by the demineralization of the inorganic portion and destruction of the organic substance of the tooth, which often leads to cavitation. Now, as we all know, every hard tissue has an inorganic portion and organic portion. The hard tissues of the tooth, that is enamel, dentin, cementum, etc., they also have an inorganic portion and then the organic portion. So, there is demineralization of the inorganic portion and destruction of the organic substance of the tooth, which often leads to cavitation. This is the definition given by Schaeffer's. Now, how do we classify dental caries? It is classified according to the morphology of the anatomical site of the lesion. It could be pit and fissure or occlusal caries, smooth surface caries, linear enamel caries, or root caries. Now, according to the dynamics with regards to the rate of caries progression, it could be acute dental caries or chronic dental caries. Based on the chronology at which age the caries occurs, it could be early childhood caries, which is again divided into nursing bottle caries and rampant caries, and adolescent caries or adult caries, which occurs in the adults. Based on the severity, it is classified as incipient caries, occult or hidden caries, and frank cavitation. Based on the progression, it is classified as arrested caries, recurrent or secondary caries, or radiation caries. Now, there is a G. Black's classification for caries, which is divided into class 1 lesions, which involves the pits, fissures, and the defective grooves. Class 2 lesions involving the proximal surfaces of the bicuspids and the molars, and class 3 lesions which involves the proximal surface of the anterior teeth that do not involve the incisal angle. Class 4 lesions found on the proximal surfaces of the anterior teeth that involves the incisal angle. Class 5 lesions that are found at the gingival third of the facial and lingual surfaces of the anterior and posterior teeth. And class 6 is Simon's modification, which is the lesions involving the cuspal tips and the incisal edges of the teeth. Now, a few points about pit and fissure caries. It occurs on the occlusal surface of molars and premolars. It also occurs on the buccal and the lingual surface of molars. It appears brown or black and soft and you get a catch on the fine tip of an explorer. Smooth surface caries, it is seen on the smooth surfaces, that is the proximal surfaces. It is also seen on the gingival third of the buccal and lingual surfaces. Root caries, it is seen on the root surface. Now, coming to acute dental caries, it has a rapid clinical course which results in early pulpal involvement. The age group which is affected by acute dental caries are generally 4 to 8 years and 11 to 18 years. The initial entrance of the lesion remains small so that the saliva cannot enter the small opening to neutralize the acid formed. It does not show formation of dentinal sclerosis, and process is so rapid that there is little time for reparative dentin formation, and the dentil is light yellow in case of acute dental caries. Pain is a very prominent feature in case of acute dental caries. Rampant caries is a type of caries which occurs on the surface of the teeth that are relatively carious. It is sudden, rapid, and almost uncontrollable. It involves the proximal and cervical surface of the mandible incisors also. There is 10 or more increment of caries or new carious lesion every year. Nursing bottle caries is attributed to the nursing bottle containing milk or milk formula or fruit juice or sweetened water. Sometimes the sugar or a honey sweetened pacifier is also used in a nursing bottle, and is seen as a clinically widespread carious destruction of the deciduous teeth. The important point to distinguish between nursing bottle caries and rampant caries is that in case of rampant caries, all the incisors are involved, whereas in case of nursing bottle caries, the mandibular incisors are spared. Adolescent caries occurs in people above 11 to 8 years of age. It is seen on the surface is relatively considered immune to caries, and there is rapid progression and there is no time for reparative dentin formation. Chronic dental caries, it involves pulp over a larger period of time. The pulpal involvement is late in this case. The entrance to the lesion is much larger. The dentin is deep brown in color. There is minimum softening of dentin and much destruction of the tooth surface. Recurrent caries, it generally occurs below the restoration, generally seen in the gingival margins of the class 2 and the class 5 restorations and rarely on class 1 restorations. It is soft at the margin of the filling and detected with an explorer. Recurrent caries produces a leaky margin. Arrested caries is a type of caries where the caries is arrested and it becomes static or stationary and does not show any tendency for further progression. It appears as brown, stained, polished and is very hard. Radiation caries occurs due to the therapeutic radiation given for the orificial lesions and it causes amputation of the crown surface. Incipient caries is the initial caries which is seen as a white spot. It is differentiated from other developmental disturbances because upon wetting the carious lesion disappears while the developmental disturbances persist and requires air drying to become visible. Occult caries is also known as hidden caries. It is a lesion that is not diagnosed but detected only on radiographs. Coming to the epidemiology of caries, caries is considered to be a disease of the modern civilization because the prehistoric humans rarely suffered from it. Caries in such persons was seen below the contact area and also on the cement enamel junction. Now, if you see caries, it occurs universally. No human being is immune to caries. It is the commonest infection to occur in the oral cavity. It occurs more commonly in modern men because they use processed soft food and whereas the primitive man's diet was coarse, raw and mostly uncooked. Now, coming to the prevalence due to race, people living in the same geographic area but belonging to different race have differing caries incidence. Chinese, blacks, Indians have a lesser caries incidence than the Caucasian whites. Age, dental caries is more prevalent in children up to 12 years. The incidence decreases somewhat in the younger and the middle age group and the incidence again increases by the old age. Gender, females have a more incidence of caries than males. That's because the teeth in females erupt earlier compared to the males. Familial, a familial pattern, hereditary pattern is also evident. Children of parents with low caries experience also show a lesser caries incidence and vice versa. Coming to the etiology of dental caries, the theories of dental caries, the early theories are the worm theories, endogenous theories, chemical theories, parasitic theories. Modern theories are acidogenic theory, proteolytic theory, proteolytic chelation theory, sucrose chelation theory, autoimmune theory and sulfatase theory. We won't go into the early theories. We will come to the modern theory, out of which the Miller's chemico-parasitic theory or the acidogenic theory is the most commonly accepted theory. It was proposed by Willoughby D. Miller in the year 1890. It's a blend of two theories which states that caries is produced by acids produced by the microorganisms of the mouth. He says that dental caries is a chemico-parasitic process consisting of two stages: decalcification of enamel and dentin, which leads to total destruction, that is the preliminary stage; dissolution of the softened residue, which occurs in the subsequent stage. The acid which affects the primary decalcification is derived from the fermentation of the starches and the sugars lodged in the teeth. The evidence for this theory is that acid was present within the deep carious lesion. Bread or sugar incubated at 37 degrees with saliva could decalcify the entire crown of a tooth. There is correlation between cariogenic bacteria in the saliva and the caries activity. The pH of cavities was lower than that of the normal teeth. Drawbacks: they are unable to explain the predilection of specific sites on the tooth to caries. What about the initiation of smooth surface caries? That is also not explained. And the question as to why some of the populations are caries free is also not explained. The phenomenon of arrested caries is not also explained. There are three factors in case of acidogenic theory: the carbohydrate substrate, the oral microorganisms which act on that and produce acid production, and finally the acid which causes dissolution of the tooth minerals. Coming to the role of carbohydrate, primitive men who had relatively low caries incidence manifested an increase in caries incidence after exposure to civilized or refined diet. Presence of readily fermentable carbohydrate is responsible for their loss of caries resistance. The karyogenicity of dietary carbohydrate varies with the frequency of injection, physical form, chemical composition, route of administration and presence of other food constituents. The sticky solid carbohydrates are more karyogenic than the liquid form of carbohydrates. Soft retentive foods are more karyogenic. refined pure carbohydrates are more carcinogenic than the crude form. Carbohydrate that is cleared rapidly from the mouth by saliva and swallowing is less carcinogenic than those which are slowly cleared. Meals rich in fat, protein or salt decreases the oral retentiveness of carbohydrates. Polysaccharides are less easily fermented by plaque bacteria than monosaccharides and disaccharides. Now coming to the microbes which are responsible for caries. The microbes which are responsible for caries are Streptococcus mutans, Streptococcus salivarius, Streptococcus meteor, Streptococcus milleri, Streptococcus oralis, Streptococcus sanguis, Lactobacillus acidophilus, Lactobacillus casei, Actinomyces viscosus and Actinomyces naslundi. This is about how the various microorganisms localize in the different areas or the different surfaces. Coming to Streptococcus mutans, which is the most important microorganism responsible for caries. It was first detected by Clark in 1924. It is a catalase negative gram positive cocci. It synthesizes insoluble polysaccharides from sucrose. It is more acidic than other streptococci. There is no colonization in the absence of teeth, and it can live on a pH as less as 4.2. Role of acids. The exact mechanism of carbohydrate dehydration to form acid in the oral cavity by bacterial action is unclear. It occurs through enzymatic breakdown of sugar. Acids formed are mainly chief lactic acid, aspartic acid, butyric acid, acetic acid, propionic acid and glutamic acid. That is about the acidogenic theory or Miller's chemicoparasitic theory. We come to the next theory known as the proteolytic theory. As the name suggests, there is organic or protein elements which are the initial pathway of invasion by the microorganisms. It means that the organic component is first lost by proteolysis, followed by the loss of inorganic content that has been made more susceptible to acid attack. It was proposed by Gottlieb in 1944, which says that the caries is a proteolytic process. The microorganisms invade the organic pathway and destroy them in advance. Acid formation is accompanied by proteolysis. The proteolytic enzymes attack the enamel lamellae, tufts, rod sheaths and walls of the dental alveoles. The proteolytic organisms produce a yellow pigment which is characteristic of caries. Now, what are the drawbacks or the demerits of this theory? There is no evidence to support that the claim that the initial attack on enamel is proteolytic. Notabiotic rats were fed with proteolytic organisms, but caries did not occur. The third theory is called as the proteolysis chelation theory, in which there is simultaneous microbiological degradation of the organic components and the dissolution of the minerals of the tooth by a process known as chelation. According to this theory, dental caries is a bacterial destruction of the tooth where the initial attack is on the organo components of the enamel. The breakdown products of this organic matters has chelating properties and thereby dissolve the minerals in enamel. This results in the formation of substances which form chelates with the mineralized components of enamel and decalcify at enamel at a neutral or even a alkaline pH. Drawbacks: whether the initial attack of dental caries is on the organic and inorganic portion of the enamel is not clear, and it is stated that both may be attacked simultaneously. The sucrose chelation theory, which was proposed by Aguilers and Laura in 1967, proposed that sucrose itself and not the acid derived from it can cause dissolution of the enamel by forming an ionized calcium saccharide. That is, it forms chelating agent and forms calcium saccharide, thus removing calcium from enamel. Drawback is that the sucrose is rapidly metabolized to form acid and polysaccharide, hence it is not present for a sufficient time to chelate, and calcium chelate saccharide is formed only at a high pH. The next theory or the fifth theory is autoimmune theory, which was proposed by Burke and Jackson in 1966. It analyzed caries epidemiological data and suggested that genes partly inherited and partly mutational determine whether a site on a tooth is at a risk. The few odontoblasts which were damaged by autoimmune mechanism alter the defensive capacity of the enamel and dentin and lead to dental caries. The last theory is the sulfatase theory, which states that bacterial sulfatase hydrolyzes the monocatin sulfate of the enamel and quaternary sulfate of the dentin to produce sulfuric acid that in turn causes decalcification of dental tissues. The hypothesis is unlikely because concentration of sulfated polysaccharides in enamel is very small. It is not readily accessible as a substrate for enzymatic degradation. Now, there is a concept called as multifactorial concept of caries etiology, which was proposed by Newburn in 1982. It says that caries is an interplay of four factors: the host and the teeth, the microorganism, substrate and the time. The host factors of the tooth which are the composition of the tooth, the morphological characteristic of the tooth, the position, and the saliva, which the factors which affect the saliva are the composition, the pH, the quantity, viscosity, and the antibacterial factors, diet, physical factors and local factors, and the systemic condition. Now you come on to the tooth. The composition of the tooth initiates caries formation, and Armstrong has reported a significant difference in the fluoride content of a sound caries and carious tooth. It says that in case of sound tooth, the fluoride part per million is 410, whereas in case of carious teeth is only 139. That means fluoride is very important for caries prevention. The surface enamel is more resistant than the subsurface enamel. Surface tends to accumulate more of fluoride, zinc, iron, and molybdenum. It is highly mineralized. The subsurface contains more carbonate, magnesium, and sodium. It has decreased enamel density and permeability with age. The morphological characteristic: the presence of a deep, narrow occlusal sphere or a buccal and lingual pits predispose to the development of dental caries. It tends to trap more of food, bacteria, and debris. Attrition leads to the flattening of the inclined plane, providing less opportunity for food entrapment in the fissures, less predisposition to caries. The position: man aligned or teeth with malocclusion have more chances of caries formation because it favors the accumulation of food debris and difficult to cleanse, thereby the person is more susceptible for caries formation. Now coming to the saliva, the composition of saliva varies. The inorganic phase of the enamel consists of crystalline hydroxide, essentially in the form of calcium and phosphate complexes. These complexes usually dissociate as pH drops. Under normal circumstances, the saliva is supersaturated with enamel apatite, which prevents the enamel from dissolving and tends to precipitate apatite on the surface of the enamel. The pH at which the particular saliva ceases to be saturated with calcium and phosphorus is called critical pH, and below this value the inorganic material of the tooth may dissolve. The critical pH is 5.5. The buffering capacity of saliva is a very significant property that affects the dental caries process. The bicarbonate can act as a salivary buffer by losing carbon dioxide rapidly. It diffuses into the dental plaque easily and neutralizes the acid formed from the carbohydrate by the organism. It brings the pH to 9. Hence, higher the salivary flow rate, there is a greater buffering capacity of the saliva. Quality of saliva: a mild increase or decrease in the flow of the saliva has little significance. Total or near total reduction adversely affects dental caries. There is exacerbation of dental caries because of rapid accumulation of plaque and decreased removal of bacteria and food debris. The normal salivary secretion is 700 to 800 ml per day. It is decreased in conditions such as Sjogren syndrome, therapeutic radiation to the head and neck region, surgical removal of the salivary glands, drugs like atropine, conditions like diabetes mellitus and Parkinsonism, congenital absence, malformation of salivary glands, acute viral infections involving the salivary glands, anxiety, mental stress, and depression. Viscosity of the saliva is not very important. Antibacterial property is very important. Lysozyme is an hydrolytic enzyme found in the saliva. It can lyse many karyogenic as well as non-karyogenic streptococci. It is found that lysozyme activity is significantly greater in group of caries-free children than in caries susceptible group. Immunoglobulins: secretory immunoglobulins have an agglutinating activity against oral isolates of alpha hemolytic streptococcus. Hence, it prevents adherence and colonization. Now, diet. This comes in the host factor. The physical form. The diet of the primitive man, as I told you, contains food which had a large amount of roughage and cleanses the teeth from adherent debris during masticatory process. The presence of sand and soil in incompletely cleaned vegetables induced attrition and occlusal and proximal surface attrition, which causes a reduction in the decay. The diet of the modern man is soft and refined, which tend to cling on the tooth and are not removed due to the lack of roughage, and reduction in mastication also is caused because of softness of the diet. Mastication of food reduces the number of cultivable oral microorganisms. Carbohydrate content of the diet is a universally accepted factor in the causation of dental caries, can be voluntarily altered as a caries preventive measure. The physical properties of food are: the foods that improve the cleansing action decreases caries. The foods that reduce the retention of food within the oral cavity and increase the salivary flow have to be encouraged in an everyday diet. The prevalence of caries in the native population was low because their diet did not contain any sucrose or other amounts of sugar, and where they were minimally found in fruits and vegetables. As their diet changed to include products containing sugar, their caries prevalence increased. To conclude, an increase in carbohydrate, mainly sugar, definitely increases the caries activity. The risk of caries is greater if the sugar is consumed in a form that will be retained on the surface of the tooth. The risk of caries increases if sugar is consumed between meals. Upon withdrawal of the sugar-rich foods, the increased caries activity rapidly decreased. So that's the conclusion. So a person has to decrease the amount of sugar and maintain the teeth to reduce dental caries. Thank you very much.